I'm super excited to introduce our next speaker, Dr. Andrew Deutsch. Dr. Deutsch did his undergraduate education at the University of Illinois, Urbana-Champaign. He also did a master's degree there, and then went on to a master's degree at Rosalind Franklin and an MD degree also there, the Chicago Medical School, Rosalind Franklin, and then did obstetrics and gynecology residency at Lutheran General, and has been a teaching faculty member there, working very closely with resident doctors and also with University of Illinois Chicago students. So we connected there as well. Last year I spoke with Drew about doing AI and obstetrics and gynecology, women's health, and I will share with you that he is one of a very few in the world right now that is an expert in this field. So you are very fortunate to hear his update on AI and women's health.
Thank you, and thank you for having me. I'm Andrew Deutsch. As we normally do, we start with disclosures, and I put on here that I have no financial disclosures. However, I will admit to you all, I did put this presentation through AI just to make it look pretty, as most of you have, I'm sure. So we're talking today about AI in women's health. I'm coming to this presentation thinking, as an obstetrician-gynecologist, what guidance do I have for the use of this technology, artificial intelligence? And Mel kind of mentioned I'm an OBGYN in clinical practice. I have a private practice, so I see patients. I work at a hospital that has OBGYN residents, and I'm also the Co-Director of Ambulatory Education there, so I'm teaching residents about women's health. And in my role at that hospital, there's also students that come through. So Chicago Medical School and UIC have students that come through, and I help teach them too. In this capacity, I really have no formal training in AI, and everyone's asking about it. And I'm thinking, what do my governing organizations recommend about the use of AI? You know, this is an important question that everyone wants to know. So ACOG, the American Colleges of Obstetrics and Gynecology, is the big governing body that often speaks to the standard of care for practice in OBGYN. I did some digging and tried to find, is there any information or statements about the AI in women's health? There is a practice management bulletin about health, IT, and informatics, and if you dig deep in there, they have one statement. This is the statement that they wrote: the view that AI amplifies and augments rather than replace human intelligence emphasizes the need to ensure that when employing AI in healthcare, it does not replace the important elements of the human interaction in medicine, but rather focuses on improving the efficiency and effectiveness of that interaction. So a little long-winded. What does that mean? They talk about AI as health information technology. So it's kind of like an electronic medical record or a telehealth platform. They have the view that AI is augmented intelligence, meaning that it's meant to be used for decision making but not replace that decision making of the human. And ACOG also prohibits the use of their content to train AI. So there's a lot of large language models out there, but ACOG's public-facing patient education materials explicitly prohibit the use of their content to train generative AI models or large language models. They emphasize the need and the concern around data security and the appropriate use of that medical information. I found this quite interesting, being an educator. It makes you wonder where some of these students and residents are getting their information from. When you look at ACOG itself, they have not released a single comprehensive official policy statement solely devoted to artificial intelligence in clinical practice. So besides that one blurb buried deep in a practice bulletin, there's no official statement on the use of AI in medicine. Tried to dig a little deeper. All these acronyms up here account for most of the subspecialties in obstetrics gynecology. You have maternal fetal medicine, which is the high-risk obstetric doctors, reproductive medicine, oncologists, pelvic surgeons, minimally invasive surgeons, pediatric adolescent gynecology, family planning. None of them have an official statement or committee opinion. I will say that those groups have some task force that have been set up, some special interest groups that are looking into this, but it really shows the need for a conference like this, where we can find out what clinical recommendations there are. And so that's why we're all here today, to further this collaboration between AI and medicine. There's some key principles to do this. When I'm looking specifically at clinician oversight of these AI instruments, validation of those tools, training of those tools, and the ethical implementation in practice. And in women's health specifically, I found that there's some big categories for use cases. There is imaging. We've seen a lot of talks about that today, how useful AI can be in imaging. There's predicting complications that can happen. There's clinical decision support systems that can help clinicians make decisions, and then there's training models. So this slide here kind of summarizes that. It's a little busy, but if you look closely, you can see in imaging, there are instances of AI use for fetal biometry, anomaly detection. There's people using MRIs for fibroid subcategorization. There's cancer imaging. And you see benefits of enhanced diagnostic accuracy when you use AI. You see improved efficiency, and you see personalized treatments taking place. For predicting complications, there's risk for preeclampsia, there's risk for postpartum hemorrhage, stillbirth, IVF. There's many uses for these applications. And some of the benefits we see are informed clinical preparation, preventative care, and better patient counseling. Clinical decision support systems, you see examples of fetal heart rate monitoring, cancer detection, embryo evaluation, infertility management. These show improved diagnostic workflows, personalized medicine, and treatment optimization. And finally, training applications. There is ultrasound training taking place. There are mixed reality delivery simulators, augmented reality surgical training that is happening. And what you can see from these is accelerated skill acquisition, real-time feedback, and safer patient care. So today, when I was putting together this talk, I thought, what are some of these use cases, some current examples in the literature? And I chose to highlight a few that I think are important. This is by no means comprehensive list, but these are some recent updates that are really important in women's health. This first article, Effectiveness of Artificial Intelligence-Assisted Colposcopy in a Resource-Limited Population, was published in the Journal of Obstetrics and Gynecology, what we call the Green Journal, in July of 2024, last year. Cervical cancer, as we know, remains a significant health burden, especially in resource-limited areas, due to limited access to skilled colposcopists and diagnostic variability. The colposcopy is the standard procedure for identifying cervical intraepithelial neoplasia, or what we call CIN, and identifying cancer, but is highly operator dependent. Artificial intelligence-assisted colposcopy aims to improve this. So the question, can AI improve diagnostic accuracy, consistency, and in particular, this is a theme we see over and over again in resource-limited areas where clinicians are scarce. This was a cross-sectional study in a resource-limited setting. It took place in China. They had 825 women with HPV positive or cytology suspicious for cervical dysplasia, and each participant underwent conventional colposcopy and AI-assisted colposcopy. They measured outcomes, sensitivity, specificity, positive predictive value, negative predictive value, area under the curve for identification of CIN 2 and 3, and they used pathology as the gold standard. About 12% of these patients were diagnosed with CIN 2 and 6% with CIN 3, and that's an important classification because that CIN 2 or 3 is classified as high-grade dysplasia that we would like to treat as opposed to observe. And when you look at the results, it's pretty impressive. The sensitivity for CIN2 for conventional colposcopy was around 85.9%. When AI does it, it's about 96%. And when you incorporate AI together, they were getting 100% sensitivity for diagnosis. They split this into some subgroup analysis: postmenopausal women and junior colposcopists. In postmenopausal women, AI method had 100% sensitivity versus the conventional, which was around 85%. And the same goes for junior colposcopists, which is less than 10 years of experience. They were seeing 100% sensitivity in the AI-assisted group. So, what were their conclusions? AI-assisted colposcopy significantly improved sensitivity for identifying these precancerous and cancerous lesions, especially for junior clinicians and postmenopausal women. AI support is particularly available where experienced specialists are limited or those that are in training. Limitations include operator familiarity, image quality demands, and the need for broader validation in diverse settings. So you see that those who can access this technology can really improve outcomes. And this is something that's important because it supports equitable and effective cervical cancer screening even in low resources settings. The second article that I'd like to highlight is Diagnostic Accuracy of an Integrated AI Tool to Estimate Gestational Age from Blind Ultrasound Sweeps. So this was published in JAMA, the Journal of American Medical Association, in August of 2024. A little bit of background. Accurate gestational age assessment is crucial for optimal prenatal care. Access to ultrasound is limited in low resource settings. I don't know if you're seeing a theme here, but a theme is beginning to emerge. This technology is particularly helpful for those with low resources. Traditional ultrasound dating requires skilled operators and high-end equipment. The study aimed to determine if a low-cost, AI-integrated handheld device was operable by novices and could match expert sonographers for gestational age estimation. This was a prospective diagnostic study. It took place at several sites. They used 400 pregnant women, singleton, that had no known anomalies. And gestational age was established by expert sonographers first in the first trimester, which is our standard of care, using transvaginal crown rump lengths. At follow-up visits, 14 to 37 weeks, novice users who were trained for only, on average, 1 day, performed blind sweeps. So what that means is these blind sweeps were done on the abdomen with an AI-enabled device where they would follow a pattern shown by the computer, go up, down, left, and right, and then the system would be able to analyze what images were seen. The primary outcome was mean absolute error of gestational age, and mean absolute error was calculated by comparing each method. So the estimate to the previously established gestational age was considered equivalent if the difference fell within a prescribed margin of 2 days compared to the gold standard, or plus or minus 2 days. What they found was that the AI-enabled tool matched expert sonographers for gestational age estimation between 14 and 37 weeks, difference of just 0.2 days. Novices achieved this after only a single day of training, and the tool performed robustly in both study sites and with patients of high body mass index, which can sometimes be an issue with ultrasound. Real-time AI analysis was accomplished entirely on device, and this required no internet connectivity. So comparing this, we can see AI-guided novices achieve nearly identical accuracy to experts for mid and late second trimester gestational age estimation, which is something particularly important for obstetricians. And this integrated AI ultrasound solution enables accurate gestational age estimation by unskilled users, as I just mentioned, making high-quality prenatal care more accessible globally. The findings suggest this technology could transform care in low and middle-income countries where expert sonographers are scarce, and the study recommends future research in high-risk pregnancies and later gestational windows for further validation. The third article I'd like to highlight that's looking at imaging is AI to assist in the detection of fetal anomaly during ultrasound scan, and this was a randomized controlled trial. This was published in the New England Journal of Medicine in July of 2024. Fetal anomaly ultrasound screening is critical for early detection of congenital abnormalities, especially congenital heart disease. Sonographer workload and expertise vary, and missed or late diagnoses remain a concern. Artificial intelligence offers a potential solution to assist sonographers by automating image acquisition, labeling, and analysis to improve diagnostic accuracy and reduce cognitive load. This was a randomized controlled trial comparing AI-assisted versus standard fetal anomaly ultrasound scans. It was done in London at a teaching hospital. They recruited 78 pregnant women undergoing screening for either healthy fetuses or those with known congenital heart disease. The AI tool performed the automated fetal biometry, and they compared it to standard manual scanning protocol and archived those still images. The outcomes measured scan duration, sonographer cognitive load, and detection rates of fetal anomalies. What they found is that AI assistance reduced scan duration by about 42% and significantly lowered sonographer cognitive load. Diagnostic performance for fetal congenital heart disease detection was not significantly different between AI and manual scans. Remote expert second review using AI-acquired video clips detected 89 to 97% of those cardiac anomalies, which was higher than manual review. And the video clips required longer review times than still images, but were more diagnostically valuable. So scan detection was shorter with AI assistance, 11 minutes compared to 19 minutes, and the congenital heart detection was the same. And so really these results are showing AI had the benefit of video for secondary review, that added benefit too. We see conclusions of AI tools effectively assisting sonographers by reducing scan time and workload, enhanced efficiency during anomaly screening. Secondary AI-enabled video review improves detection rates beyond manual review, which suggests a robust adjunct for fetal screening programs. Further validation across multiple centers and ultrasound systems is needed to confirm broad applicability and long-term clinical impact. Another amazing use of AI in women's health. Imaging, we've seen a lot, especially with the last talk, of use cases for AI. Important, another role is predicting complications. This article, the role of cell-free DNA biomarkers and patient data in the early detection of preeclampsia, an artificial intelligence model, was published in March of last year in the American Journal of Obstetrics and Gynecology, what we call the Gray Journal. One of the reasons predicting these complications is so important is because of the risks involved with obstetrics and gynecologic surgery. Preeclampsia is one of the leading causes of maternal and fetal morbidity, and with early detection essential for prevention. Traditional risk models based on maternal history alone have poor predictive accuracy. Cell-free DNA, which is getting performed in most pregnancies now, is a marker for routine, non-invasive prenatal screening, and it presents a promising non-invasive approach to risk assessment. This study evaluated whether combining patient data and cell-free biomarkers using AI enhances the early detection of preeclampsia. So the methods used for the study were secondary analysis of the prospective multi-center SMART cohort, which included around 17,500 singleton pregnancies with known outcomes. They input data, 13 routinely collected patient characteristics, for example, age of the patient, body mass index, blood pressure, history, and they incorporated 2 cell-free DNA features, which were total cell-free DNA and fetal fraction. And they did that at the first prenatal visit. The models developed was a reference logistic regression and several feed-forward nonlinear neural networks, selecting a 1-layer neural network for final analysis. The outcomes they looked at were predicting early onset preeclampsia less than 34 weeks, preterm less than 37 weeks, and term more than 37 weeks gestational age. And the model performance evaluated area under the curve and sensitivity with a 15% screen positive rate. Out of the 17,500 analyzed, the rates were 0.4% for early onset, 1.4% preterm, and 2.4% term for preeclampsia. Higher total cell-free DNA and lower fetal fraction were linked to preeclampsia. When we look at the model performance, the area under the curve, you can see that the AI model performs similar to logistic regression regardless of time point analyzed. So whether it was early, preterm, or term, the numbers were pretty similar. For early onset, less than 34, when you remove that cell-free DNA from the model, the sensitivity drops 6.9%, and it's negligible for preterm or term. So AI models perform similar to logistic regression models. Cell-free DNA significantly increases the sensitivity for early onset preeclampsia detection, less so for preterm or term. And this approach offers potential for scalable, non-invasive risk prediction in routine care without the need for additional costly biomarkers or ultrasound. Further refinement and validation in diverse populations are needed. So the potential is there. Like most things we're talking about today, we're in early stages. And this is just talking about preeclampsia. There are many others looking at postpartum hemorrhage risk and other significant risks that happen in women's health that someday soon will hopefully be available. Next article is looking at clinical decision support. The real-world use of an artificial intelligence-powered clinical decision support tool for ovarian stimulation. This was published in the Journal of Fertility and Sterility in January of this year. Individualization of ovarian stimulation in IVF is complex, often varying by clinician and based on experience, leading to inconsistency in medical use, outcomes, and cost. AI decision support tools are being developed to optimize this process, aiming to standardize dosing, reduce medication exposure, and maintain efficacy. Prior work demonstrated AI could predict optimal gonadotropin doses. The current study aimed to evaluate real-world effectiveness of AI-based support for dosing and trigger timing in clinical IVF settings. This was a retrospective cohort study with historical cohorts, 292 patients who had underwent ovarian stimulation with AI-assisted dose and trigger decisions. And it's important to note these were AI-assisted. They compared this to 292 matched historical cohorts who were treated by the same clinicians without AI assistance. Their endpoints were starting FSH dose, total FSH dose, and number of mature oocytes retrieved. In matching, these patients were matched for age, BMI, AMH, antral follicle count. These clinicians were highly experienced, minimizing operator bias. So what did they find? They found that the AI-assisted group received significantly lower doses of FSH. There was no difference in the mature oocyte yield. There were no cases of moderate or severe ovarian hyperstimulation in any of the groups. And subgroup analysis by age suggested potential for individualized benefit, but difference in oocytes were not statistically significant. So when you look at the AI-assisted group, they received these lower started doses, 397 versus 443 for the historical cohort. They received lower total doses, 4,100 instead of 4,600 roughly, and the number yield was similar between the two. So in conclusion, the AI-powered dosing tools reduced FSH use without compromising yield, safety, or outcomes. The effectiveness demonstrated even among experienced clinicians supported broader utility for standardization and efficiency. The potential benefits of this include cost savings, reduced medication waste, improved equity by standardizing care across clinicians and centers, and the limits were that this was a single center, early adopter clinicians. Broader multi-center validation is needed. Why is this an important study? This is an elegant example of AI use in clinical decision support. Of course, the research is still in its infancy, but fertility in particular is a very important topic that's on the cutting edge of AI in terms of fertility treatments and IVF. This sixth article I've chosen to highlight is the efficacy of large language models and their potential in obstetrics and gynae education. This was published in the Journal of Obstetrics, Gynecology, and Science in October of 2024. And to me, it was of particular interest because student education is one of the areas I'm passionate about. I found this study particularly interesting because so many of our students are using these tools. The background is the potential use of large language models like GPT 3.5 and 4 in medical education, specifically in obstetrics and gynecology. And OBGYN education traditionally relies on memorization and clinical experience, but it can benefit from AI to support understanding and problem solving. This study aimed to evaluate how well these models perform on OBGYN clinical knowledge exams compared to resident physicians. So they examined 116 text-based questions. They excluded image-based questions from an annual exam taken by residents at 3 hospitals over 4 years. This study was done in Korea. They compared scores of GPT 3.5, 4, and 100 residents across first to third postgraduate years. The questions covered broad OBGYN topics, and the assessment focused on understanding the clinical data and problem-solving capabilities of these large language models. The average score over 4 years, the first model, 3.5, was only around 38, 39%. When they went to GPT-4, it was 79%. The residents averaged around 79 to 83% depending on their year. There was no statistically significant difference between GPT-4 and residents, and GPT-4 excelled particularly in obstetric-specific questions, around 90% versus 3.5. So GPT 3.5 did not do so well, only about 39% correct. But when they went to GPT-4, this matches or exceeds the resident's physician performance. And as far as I know right now, there's GPT-5, which we can assume is getting better. There are also some of these large language models which are able to analyze pictures which they didn't incorporate into this either. So in conclusion, 4 demonstrates near human accuracy on an OBGYN clinical knowledge exam for text-based questions. These large language models have the potential as tools to augment resident education, and they're limited because they cannot interpret all images or real-time data, which is critical in OBGYN training. These tools should augment, not replace, human clinical expertise and patient interactions. That's something we were highlighting earlier, that ACOG believes that they are tools to be used. And this calls for an educational shift towards AI integration into the education to improve learning efficiency and clinical care quality. So AI is offering advanced problem solving and clinical reasoning support. As we all know, residents and students and even attendings are using these tools. And this is really in line with what ACOG is saying for augmented intelligence. It should support current providers, not replace them. So those were some research studies that were looked at, and we're thinking research versus practice. What is currently being used? The big conclusion to the question, what should a general OBGYN know? We know AI is coming, how can we integrate? So I pulled up some examples of current research, and I wanted to examine those too. But first, I just wanted to mention that all United States FDA-approved artificial intelligence medical devices in women's health are clinically validated through retrospective studies that assess diagnostic performance using previously collected data. The majority of these devices, especially those for breast cancer screening, are cleared via the 510(k) pathway, which requires demonstration of substantial equivalence to a existing device. And what does that mean? That they can perform as accurately as standard clinical methods or better. They provide meaningful benefit in real-world or simulated clinical settings, and that it can be generalized to a diverse patient population and environment. About 56% of the FDA-approved AI medical devices had clinical performance studies performed at the time of approval, while approximately only 24% explicitly stated that no such studies had been performed. The remaining devices either did not specify validation status or had unclear data, which is a little concerning. Of those clinically evaluated, most studies were retrospective, around 38%. Only 8% were validated prospectively, and just 2% underwent randomized controlled trials. So this is a slide looking at some FDA-approved enabled medical devices that are used currently in obstetrics. Most of these are on imaging, ultrasound imaging to be particular. These first 3 look at OB point-of-care ultrasound, so they're looking at fetal biometric measurements, fetal heart rate imaging to ensure correct fetal heart views, cardiac imaging to optimize heart acquisition. And this last one, Paragen, is very interesting in that it's looking at fetal heart rate patterns during labor. This helps clinicians identify risk factors during labor, and is particularly interesting. When you look at the validation for these studies, they were all validated using reader studies, where the clinical performance with and without AI is compared. And so that's obstetric devices. Breast health, we kind of touched on the last talk. There are many imaging for breast. The breast cancer detection can look at 3D mammograms. Ultrasound can compare benign versus suspicious nodules. And automated 3D breast ultrasound can improve cancer detection. There's ongoing prospective studies on that one. The other ones are based on retrospective benchmark studies. Sexual and reproductive health, there's devices that can look at IVF embryo viability. We talked a little bit about IVF dosing and regimens. When you actually embryologically look at the eggs, there's AI that can analyze those, and those prospective trials are underway. Colposcopy, we talked about a little bit about that, how it can look for cervical cancer. There's a device that can be used for that. There's a device that monitors fertility and provides contraceptive guidance, which is based on algorithm benchmarks. And there's even a pelvic floor device, which uses motion sensor wand to help strengthen the pelvic floor. It gives feedback to the patient using AI-guided coaching. And this device is used randomized controlled trials in over 200 women to show increased strength of the pelvic floor and decrease in urinary incontinence and issues such. So this is an area exploding with clinical tools, also consumer products. As a clinician, more and more patients are coming to the office presenting with data already acquired from some of these devices or using these devices and asking questions about it. And so it's important that we can give them honest feedback about what these devices are telling them and guidance on what to do with that. Devices available in gynae imaging, pathology we talked a little bit about today, cervical, breast, endometrial pathology. There's AI-assisted pathology, and there's imaging triage that can flag urgent findings on CT or MRI for postpartum patients looking for PE, which was also mentioned earlier. There's devices in development to analyze MRI images to look at fibroids to help plan surgery. A lot to look forward to. So, AI in women's health. We are all here today because of the innovative technology of AI. In women's health, research studies are confirming the potential use cases in imaging, predicting complications, clinical support, and education. AI-enabled medical devices are already available and contributing to patient care. Clinicians and educators will be looking to organizations like this one for guidance on what to do going forward. So regardless of medical specialty, clinicians and educators need to continue to talk about, do research, and collaborate with each other about this topic of AI in medicine. So we're excited. Any questions?
Hey everybody, John here. Thanks for listening to another episode. If you enjoyed what you heard here today, please check out our website at www.americancollegeaim.org. Sign up to become a member. Also, save the dates, October 9th and October 10th, 2026. We'll be back live in Chicago, Illinois at the McCormick Place Convention Center for our second annual live scientific session. Sign up at the website to attend. Until then, we'll see you all on the next Melvin Monday. Thanks for stopping by. See ya.